Thank you for joining us today as we delve into the critical advancements in breast cancer detection, treatment strategies, and collaborative efforts shaping patient care. Our topic for today is innovations in breast cancer detection and treatment. Breast cancer is a common malignancy affecting both women and men. Early detection through self examination and screening is crucial for effective treatment. Personalized therapies based on genetics have transformed treatment approaches and outcomes. We are honored to have with us Dr. Jeyhan Dhabhar. Dr. Jeyhan is a medical oncologist and hemato-oncologist with MEPS, MD, and DNP in medical oncology. He specializes in precision oncology, focusing on maximizing treatment benefits with minimizing toxicity. He's a member of various international oncology societies. He also serves on editorial boards and is also involved in various educational workshops. So, welcome, Dr. Jehan.
Thank you. Thank you for the kind introduction.
Yeah, so Dr. Jehan, what are the signs and symptoms of breast cancer that individuals should be aware of, and when should someone seek medical evaluation?
So, in the early stage, unfortunately, breast cancer will have no signs and symptoms. We have a good 30 to 40% patients coming to our OPD who just accidentally noticed a lump and they are absolutely asymptomatic. So, no, we have a very commonly patients come to an OPD. I was having bath and I just felt something hard in my breast.
Yeah.
Or that day my child hit me. We have young patients who are 30, 34. So my child was playing and he hit me and I felt something over there. So this is a good 30-40% patients who are asymptomatic.
Yeah.
The common symptoms otherwise that we see are any changes in your breast, any changes in the contour of the breast, any discharge from nipple, if one breast seems bigger than the other, if you feel any lumps or swelling in your axilla. These are some signs and symptoms that we should look out for. In the advanced stage, we unfortunately even today we have 20 to 30% patients coming to us in the advanced stage when the disease has spread. So that depends on the organ where it has spread to. So most commonly, the breast cancer can spread to the bones, and we have patients coming to us with back pain, which is nagging and persistently there. They have met countless orthopedics or the general physicians, and an MRI was done which showed lesions. And then after we examine them, there's a lump in the breast. So even this is a scenario that we see. Sometimes patients can come to us with a nagging cough because they have lung metastasis. So these are of course rare presentations. Most commonly is asymptomatic, and second we see is patients coming to us with a lump in their breast or some pain in their breast, any discharge from a nipple or an axillary swelling.
Right. So, what are the current recommendations for breast cancer screening, and how often should women undergo mammograms or other imaging techniques?
So in India, we still do not have a formal screening guideline set by the government, but we tend to follow the American Cancer Society guidelines, which say that above the age of 45, all women should undergo a yearly mammogram until they're at least 55, and then they can switch to once in 2 years if required. It is very important that we spread awareness that is something like a mammogram which you should do after the age of 45. Most of the time we forget to tell our own relatives. Being an oncologist, I miss out telling on my relatives so many times. It's very important that we talk about this more frequently. We tell people, we spread the word that get your mammogram done after the age of 45 once a year. World over, there is no strong data that tells us that breast self-examination is beneficial. But in the Indian scenario, I would say I myself and most oncologists would still recommend breast self-examination. Why? Because we live in major metropolitan cities like Mumbai, or where we have access to a mammography easily. We can just walk up to hospital, get a mammography done, get the report next day. Most of our populations in the interior of India do not have access to a mammography. So that's where breast self-examination plays an important role. In fact, in between, there was an initiative by the government of India, where they started training the Anganwadi workers to
Mhm.
tell women on how to examine their breast at the grassroots level. So that is very useful. So if they find something abnormal, they can report to a doctor, who can in turn ask them to get a mammo or a sono mammo done. So in the Indian scenario, yes, I would still recommend breast self-examination. Otherwise, a mammography yearly after age of 45, and then we can switch to a once in 2 yearly screening.
Right. Right. So, what are some emerging technologies or approaches in early detection of breast cancer that show promise, and how might they change screening practices in future?
Correct, correct. So, as I said, you know, the interiors, we don't have access to a mammo,
Mhm.
and if they don't have access, at times they can't afford it. Also, that is also a very important thing. Affordability. No, we ask the patient to do a mammo every year. Then patients may shy away from doing it because of the cost. So there is this handheld. It's called a eye mammo scan machine, which is a handheld machine. It's paired with a iPad. We have a small foundation called the NK Dhabhar Cancer Foundation, where we go to the interiors of India. We recently went to the interiors of Jharkhand. We go to the interiors of Maharashtra, where we make it a point to screen 200 to 300 women free of cost.
Mhm.
So this is the eye scan machine which can detect any suspicious lesion.
Mhm.
It is USFDA approved. The eye scan is USFDA approved, and it is handheld, easy to use. We don't require an expertise, and can detect a suspicious lesion. Of course, this lesion should be followed up with a mammography.
Right.
So the eye scan detects something suspicious.
Mhm.
The next step is to do a mammo. At least this way we can filter out
Mhm.
women who need a mammo,
Mhm.
and more patients are detected.
Mhm.
No, in almost every camp that we do, we have, I would say, minimum 2 to 3 patients coming with a suspicious lesion. And out of that 2 to 3, one or two are definitely malignant also on
Mhm.
subsequent evaluation.
Mhm.
So this is something very practical for the Indian scenario, I would say, and something that is we are already using.
That's great. So, this is how we can target the periphery. So, my next question is, could you explain the latest development in personalized treatment options for breast cancer based on genetic testing and various biomarkers?
Correct. So, no, now around 5 to 10 years back, metastatic breast cancer would be a bad disease. We
Hmm.
would patients unfortunately would not be surviving for prolonged periods. But as of today, even a stage 4 breast cancer, we have it's like a chronic disease. We have patients living together for years together with a good quality of life, which is very important. We have markers called ERPR and HER2. So in the ERPR positive subgroup, we have so many newer drugs which have come in, which we call the CDK4/6 inhibitors, like palbociclib, abemaciclib, ribociclib, and these, when combined with our conventional hormonal tablets, they can get very good disease control we can achieve with this. In the HER2 positive, when the person is ERPR negative but HER2 positive, recently an Indian company has launched a drug called pertuzumab, which once upon a time costed something to around 2.5 to 3 lakhs
Hmm.
every injection. So very elite few could afford it. But now with the Indian company, which makes it in under a lakh, it is the reach is expanded drastically. So when you give a dual HER2 blocker, we get phenomenal responses and with no toxicity,
Hmm.
very safe.
Hmm.
Thirdly, in the triple negative breast cancer subgroup, which is known to be aggressive, known to be a bad disease, no, immunotherapy has changed the scenario over there. So even in early breast cancer, when we use immunotherapy, we get excellent responses in most patients. We have to do a simple test called a PDL1.
Hmm.
And if that score is high, only on immunotherapy patients do very well. And immunotherapy, mind you, is just an IV injection, which is very safe. There's no toxicity.
Hmm.
10 to 15% of the patients can be BRCA positive. So BRCA is a gene which all of us have
Hmm.
and made famous by Angelina Jolie back in 2012 when she got herself tested for BRCA.
Hmm.
So that's a different story altogether. So BRCA, if mutated,
Hmm.
that means if your BRCA is not functioning, there is a tablet which we can offer. Secondly, in the third or fourth line, once we have used up our conventional therapy, we have a test which we do on the cancer tissue, on the biopsy specimen, which is called next generation sequencing, which is called NGS. And that can throw up some non conventional treatment options.
Yeah.
Even in the, as I mentioned earlier, in the hormone positive group, the ERPR positive group, at every step you would like to do a certain test. Like in patients we have where we have a PI3K mutation, a PIK3 mutation, what we call. We have special tablets for that.
Hmm.
If a patient has an ESR1 mutation, we
Hmm.
have different tablets for that. So then at each step, we have a special test which will help us guide therapy. So nowadays, that is the advantage. We have so many weapons to use.
Yeah.
We just need to know which one to use. And we thankfully have those tests with us in India also.
Right. Right. So my last question is, how important is collaboration among various medical specialty in managing breast cancer cases, and how does it impact patient care and outcomes?
Correct. So it's very important to always have, a multidisciplinary meeting between the medical oncologist, that is us,
Hmm.
the radiation oncologist, and the surgical oncologist. So it's very important that all of us are on the same page when we are treating a patient. Because now there are so many gray areas. Like just before this very meeting, I was talking to our radiation oncologist at Just Look, having a discussion about whether to radiate, not to radiate.
Hmm.
Because there's one, for example, if I put it in a case, there's this lady who came with a breast mass and one lesion in the liver,
Hmm.
one single cancerous spot in the liver. And we gave her chemotherapy upfront, 6 cycles with a dual HER2, as I mentioned earlier, trastuzumab and pertuzumab. Her PET is absolutely clear now. There's nothing found.
Hmm.
I wanted the radiation oncologist to even radiate that liver lesion, to give something to that liver lesion, but she said I can't see anything. It's
Hmm.
all gone with chemo only. So
Hmm.
these are just these are the conversations that we have. We usually have a tumor board also once a week where we discuss all complex cases,
Hmm.
where we come to a conclusion, what sequence to follow. At times, there's always the surgeon would like to operate, but I would say no, we should give chemo first. So this is always a this thing, but there are certain guidelines which are already set world over, and we need to discuss with the surgeon. Okay, this is my point of view, and the surgeon has to put his point of view forward.
Hmm.
And whatever is more logical is that what we follow, and what is in best interest of the patient. So it's
Right.
very important to have a tumor board,
Yeah.
and where all three of us sit together.
Right. So, with this, we conclude the session, and our key takeaway is together we can drive progress in breast cancer and help patients through innovation and collaboration. Thank you, Dr. Jeyhan.